Thank you very much for inviting me, offering this chance to give a speak here. My name is Anne Sofie Boldsen Salicath, and as I was introduced, I'm a doctor. I'm also a patient. So I'll just get started. And I have to say, I sound worse than I am actually, but I'm having a cold at the moment, so that's for the coughing. So this is me. This is the summer of 2015. You see, not a care in the world. I'm young and I'm healthy, mother of 4 kids, 4 to 13 years old. Married to a gorgeous man. He does not always look like that. I'm a medical doctor finishing the university in 2004 and has also finished as a GP in the same summer. I'm incarnated non-smoker. I have no lung cancer predispositions. I've not grown up in a smoker home or anything, so I was quite surprised when I, 6 months after this picture was taken in February 2016, were diagnosed with a non-small cell lung cancer, carrying the EGFR mutation. It was stage 3B, and I was 41 years old. In half a year, it progressed to stage 4 cancer in August 2016. So, if you look up this in the internet, this Kaplan-Meier curve will be thrown right in your face. You can see the survival curves are not very impressive. So how would we like to be met in the healthcare system when we have a diagnosis and a Kaplan-Meier curve like this? Well, there are 2 stories on how this could be done. One is how we would like to be met, and how we actually was met. This is a bit busy slide, but what I want to say here is that when I got diagnosed, I would have hoped the doctor would have said something like this to me. For instance, you have a very serious disease. And of course, though everyone is different and everybody's unique and medical processes moves fast, with the standard treatment today, the average survival is just 30 months. And you can say, why is this say this to a patient? But it isn't a secret. It is the truth. And if you go down, and all patients go home, they search and they come up with this themselves. So the doctor not acknowledging this and putting into the conversation, it can be very frightening. Okay, then we're like next step. Since the research since the standard care is so bad, the results of standard care is so bad, we are researching intensely to develop new treatments that we hope will increase the survival. We're testing different experimental treatments. Here's some information that we believe would be good for you. The treatments are selected carefully by some of the world's leading researchers in the fields. And of course, you must be aware that most of the treatments will not have the effect we want. Therefore, we will follow you closely. If you have progression, it doesn't work, we will start you in another promising trial. And if you choose to do standard treatment, that would also be okay. Spend some time, go home, find out what to do. Okay, I would have liked that. First of all, they have the same goal as me. I shall live as long as possible. They seem very competent, and they have a strong and well thought through plan. Well, so how are we met? This is this is the paper I came home with that day. Long adenocarcinoma, not good. Let's hope there's no spread. We did have information, of course, on the diagnosis. The next step, a PET scan, ... So we'll see. Prognosis, maybe years. Let's just hope it has not spread. And then almost with a chuckle, I know this old lady who comes in here every year just for her controls. Amazing. It must be like 5 years now, I believe. And also, I'm very sorry, it's a very serious condition. Try not to think too much. Don't Google. Well, we did not get any information on possible treatment options in case of localized versus advanced disease. And we didn't get any information on the possibility of mutations, which actually in young women who develop and men who develop lung cancer is very high. First reaction, Yeah, so we were spooked beyond words, and I started this offered treatment, which was a combination of 2 chemotherapeutics, cisplatin and vinorelbine, and a radiation course. And you see for the unresectable stage 3 non-small cell lung cancer, this is just the curves for pure chemotherapy. And if you look over here, if you add radiation, you can see the down, the lower numbers. You don't improve very much the survival if you add radiation. They did this on curative intent. And I have to say, when I see these numbers, I'm not very sure this is a curative intent. If I'm lucky, it is, but 80% is not that lucky. Okay, so I did what every good patient does. I started to Google. I started the research, I came in contact with other patients, and I started to understand that if standard treatment leads to almost all patients dying, it seems very stupid just to follow standard treatment. So I started asking some questions, like, can we add other treatment modalities to the treatment I'm having to make it work better? I was told, no, nothing has been proved to work. Can I do something to make treatment work better myself? No, just don't lose weight. What about after I end my treatment? Anything we can do there? No, because hopefully you will be cancer-free, so you should just enjoy life. Also, I asked, are there any trials that can be added to after I end my first-line treatment? No, we usually just wait and see. But I decided to do something more. So when this radiation chemotherapy thing was done, I asked for a restaging to find out if I was operable, and I was, in fact. I had a left lobectomy in June 2016, as they put it, on my own risk. And I asked if there was some adjuvant treatment that should be added, target drug or more chemotherapy or radiation or something, drugs during surgery. I was told, no, there's no evidence for this. And I listened. But unfortunately, 3 months later, in August 2016, I had a relapse with 3 nodules in my right lung and 1 lymph node. And after a board meeting, it was decided that I was now in curable stage 4. So I started the oral drugs targeting my mutation, EGFR, called the Tthe. It's a very good drug that helps many people. Unfortunately, resistance is often developed quite fast. So it's only a short-term treatment. So, how is life like life as a stage 4 patient? Well, what you're definitely allowed to is to follow the standard treatments. You're advised to stay away from everything else. You're advised to wait and see and hope for the best. For instance, there are no stereotactic treatment or ablation upfront done for stage 4 patients on TKI when they start, though it has actually been proven to work to prolong the time on the TKI. There are quite long intervals between the scans, even in case of growth, because the treatment options are so limited that you kind of want to you don't want to change treatments too soon. Actually, I have not been offered routine MRI scans for my brain, unless I requested it myself, except for in the beginning, of course. So many lung cancer patients can go around for a year not getting these MRI scans of the brain, though we actually know that 50% of non-small cell lung cancer develop brain mets at some point, and it can be treated. There are no routine PET scans done except unless requested. There are no additional testing of the tumor outside the standard package, and there are no, or regrettably few, trials to participate in, and then it's often used as a last option. So the impression that sunk in was that the healthcare system was content as long as I followed the offered standard treatment, as long as it could work. They have this saying, first no harm. I want to save my life. I was willing to take some risks to well-calculated risk to get there, but that's it. I wanted more of this. This is, by the way, 4 months after my lobectomy. We were on the top of Tthe. So, yeah, well-functioning lung. But we had fundamentally different goals, healthcare system and I. And I actually feel that I was given up the day I was diagnosed with stage 4. This is unfortunately routine. I'm not alone. Our healthcare system seems to give up routinely on young mothers and fathers and others who get an incurable terminal disease. And they are, in my opinion, done very few meaningful attempts to save their lives. Is it okay? Well, it is okay that you cannot save the life of a young cancer patient, but there are no excuses, I think, for not trying the absolute best. I have 3 suggestions of guidelines on how incurable, terminally ill, and maybe especially young patients should be met. First of all, I think the patient deserves a well and truthfully information on the disease and the perspectives of the treatment they have started. The healthcare system should also have as a goal to save the lives of these patients, or at least try. And 3, the hospital should offer, or at least direct patients to a variety of experimental treatments within certain limits, of course. Unfortunately, this is far from today's reality. This is a shop in the Soviet Union, and unfortunately, this is quite a good picture of the offers that incurable terminal ill patients have today. There are few or no relevant clinical trials. There are no treatments offered with an evidence lower than phase 3. And to make it even worse, when patients bring initiatives of their own, they are mostly discouraged and warned, and they're not guided or encouraged. So what do most patients do when they face this incurable terminal diagnosis when they meet this healthcare system? Well, most cancer patients die after they have received only standard treatment. It's actually a double tragedy because the patients die and the healthcare system does not learn anything from the disease. They die in vain, you can say. Many patients also try out miscellaneous and sometimes even dubious alternative treatments on their own initiative. And as was pointed out earlier, healthcare system does not learn from these experiences. And sometimes the healthcare system even refuses to follow or scan patients who are not accepting the recommended treatment, even though it was not good, the treatment. Some patients seek treatment abroad, some with luck, some not. And only a small fraction of patients are enrolled in a clinical trial during the disease course. In the USA, it's actually only 3%. And I don't know the numbers for Denmark, but I would believe they're similar. So what did I do and what could I have done? Well, I followed the standard treatment. After my stage 3B diagnosis, I participated in one trial that used high-dose radiation with chemotherapy. And I've actually not been offered a trial as a stage 4 patient. I've, on the other hand, added multiple treatments myself and are today without or almost without visible cancer. We have some scar tissue we are observing. But my disease situation could have been different, a prognosis possibly better, if I have only questioned some of the truth I've heard. Or somebody has pointed it out to me at the right time. For instance, stage 4, or even more stage 3, is it really uncurable? Well, we know that actually some stage 4 cancers are curable if you use ablation or stereotactic surgery upfront. Though the old paradigm is that once cancer gets into the lymph nodes, the blood vessels, there's no chance of a cure. But that's not entirely accurate, as said here. Could I have had this when I had my stage 4 diagnosis instead? Maybe it would have made a difference. There are actually ways you can improve chemotherapy. I won't go into details. I'm just pointing out that, for instance, melatonin has doubles the chance of survival in chemotherapy patients within a year. And loratadine, which is an antihistamine, if you take it at the same time as you do chemotherapy, there's a 24% lower risk of dying. We know that from big Danish register studies. There's something about fasting and about diet. This is a small study, 15 people, but still very much improved benefits. You see here, overall survival were increased pretty significantly. Okay, so next, if you take these two drugs, Tthe and propranolol, which are common, very used words against propranolol is for high hypertension, and Tthe is anti-inflammatory. If you take it in relation to the operation, you probably significantly reduce the risk of relapse after cancer. So why is this not tried? Also, it has been shown that if you start this targeted therapy after surgery, that prolongs the recurrence-free survival. Why was not offered this? Then there's this new, I think is very promising approach that's called repurposed drugs. Repurposed drugs are ordinary drugs that are used for their anti-cancer properties. It's ordinary drugs used for instance, diabetes, like metformin, that also has a significant anti-cancer effect. And basically, if you add this to standard treatment, you can achieve very good survival curves. For instance, adding this metformin to ordinary standard treatment with the drug I'm having increased overall survival from 19 to 27 months in non-small cell lung cancer. The price is $10 a month. So we're not discussing 1 or 2 months or 30,000 Danish kroner, what do you call it, 10,000 millions of dollars a month. We're discussing a very, very, very cheap treatment, well-known, well-used, that can lead to this kind of improvement in survival. There's another drug, itraconazole, is an oral antifungal drug. In combination with this chemotherapy, it quadruples survival from 8 to 32 months in lung cancer. Small study, yes, 23 patients, but it's a drug that we use for nail fungus for years. So it has literally no side effects. Why not try and offer patients this? And last one I want to mention here is an oral copper chelator called Tthe. It's an extremely powerful inhibitor of metastatic disease. And what it's good at is inhibiting the establishment of new growth in high-risk patients. This is an amazing trial. 75 women with triple-negative breast cancer. We all know that it's the worst kind of breast cancer because there's not much you can target there. They were all NETs. That means they have in remission. They had their metastases removed from brain or liver and wherever they had them, and they were without visible disease, but of course in very high risk of relapse. After 7.1 years, 59.3% of the stage 4 triple-negative women were alive. We would have assumed maybe only 12 months. So that's a huge, huge benefit. There are no mentionable side effects. And I take it, of course. So what have I done so far? Well, I've been researching a lot. I've been attending conferences. I've been consulting with top doctors, specialists, researchers in the field of both non-small cell lung cancer and immunotherapy. And I'm also engaging, very important, in an international patient group of mostly young progressive lung cancer patients and caregivers with the same goals as me. I've been choosing alternating diet. I've added several repurposed drugs. I already mentioned some of them. Tthe. I won't go more into that. I've added several supplements with same scientific evidence for effects, zinc, berberine, D3. I've had a personal peptide vaccine, so I was glad it was mentioned, in Germany, made on the results of a sequencing done to my tumor. I've managed to find an oncologist who don't think I'm crazy. At least he acts a little interested, and to some extent he's also adventurous and supports me in the above, even though he don't think it will work. What I'm looking into at the moment are intratumoral injections, also called in situ vaccines. What we're looking here is for both starting having a local reaction to the tumor and also a systemic one. I think it's very promising. Oncolytic therapy is another one. New promising treatment combinations. And I'm developing, at the beginning of developing a repurposed drug database where all these drugs that can be used against cancer that any GP can write prescriptions for are listed. Okay, how much time is? Yeah, I'll speed it up a little. So why do I have to come up with all these things myself? Well, what are the problems here? Lack of goal and incentive in the healthcare system. It seems it's considered maybe pointless or in vain to try to cure or treat stage 4 patients for more than standard therapy. And they have this first do no harm. There's also lack of coordination, which somebody mentioned, with the patient's wishes. For instance, a younger patient will be willing to take a higher risk to achieve higher goals. A chance of a cure significantly, or a chance of a cure or significantly prolonging life by taking well-calculated risk should be much better than just a few good years. I want more than that. Lack of flexibility in the healthcare system. There's no right to try. Normally, we don't use phase 3 evidence. There's less than phase 3 evidence for treatments to get implemented, tried out. I know there are exceptions. So what can we do? Well, this is my idea. We need to rethink our trial system. We need to branch it out so in the future 97% of all patients during the disease course will be in a clinical trial, not just 3%. We need to be much bolder in combining treatments. Combining only 2 treatments is ambitious, I think. Does anybody think it will work? We saw the cancer patients, the HIV patients mentioned the key there was a combination of 3 or 4 drugs. Maybe this is the same in cancer. Most likely it is. Searching for another thing we could do is that we can accept less than phase 3 level of evidence where there's good phase 2 evidence present. And it's because it's often expensive, time-consuming, delays the use of good treatments, and for some treatments, for instance, these repurposed drugs, it's not even realistic to do phase 3 studies because we'll pay millions of dollars for making phase 3 trials that where the patent has already run out. In this way, we can gather big amounts of information and knowledge in a short time. We can speed up the research for better treatments, maybe even a cure, and we can prolong the survival for patients here and now. We need the right to try. So glad you mentioned it, Jonathan. So this is just me trying to make an overview of what I'm thinking about. But imagine you're getting the diagnosis, and then a whole array of treatments will emerge, and then you can choose from many different setups. Please note the standard treatment in this setup is in every one of the combinations, but you combine it with different drugs. You can maybe add ablation, you can maybe add vitamin C, intercalate chemotherapy, and so on. If you have progression, you jump into another trial. If you go into remission, you can add other drugs, for instance, this copper that maybe can prevent the cancer from coming back. Has it been done? Yes. Could it work? Yes, I believe so, and it has been done, in fact. This is standard treatment in combination with 4 ordinary repurposed drugs. Metformin, atorvastatin, is a statin, mebendazole used for pinworms, and doxycycline used for acne. If you take these 4 drugs, it has almost double survival in stage 4 patients when used with standard treatments. This treatment has been carried out by a care oncology clinic in London. And now imagine, as I put in the bottom, now imagine if you added stereotactic radiation, if you added vaccines or drugs like Tthe to the copper chelator, how you could improve these numbers. Summary, yes, we can do this. To me, it seems unethical not to take advantage of the knowledge that's already there. So we can be able to try and prolong life significantly for incurable patients. If we keep repeating what we have done to this point, we will end up in the same place. We need to rethink and expand the clinical trial system dramatically to speed up the process of transforming stage 4 cancer into a chronic or even curable disease. Thank you for your attention.